So hello everyone. Now I'm starting our lecture. The lecture will be in two parts. Part one, which will be on the whiteboard, and the part two will be as PowerPoint presentation. Okay. So today's lecture is about what is pathology. So just let me know if you can see what I'm writing. So what is pathology? Okay, can you all see that? Let me see. Okay, yeah, okay, perfect. So pathology actually has different meanings, okay, but we have something which we are all we all actually agree with it. Okay, so pathology, from its name, patho means disease, and any ology, like say physiology or microbiology, is study. So study of disease. Okay, this is the general meaning of pathology. Okay, so pathology is study of disease. So actually the difference here regarding the study, how can we study pathology and study the disease, and what is the meaning of disease, okay? So diseases in general, actually from this word, dis-ease, so dis-ease, okay? So anything that actually causes pain, causes abnormality is called disease, okay? But these diseases, we have two different form of diseases. One which has structural changes, and one which has no structural changes. Okay. For example, say schizophrenia, something like irritable bowel disease. Okay. If you take any like tissue from the brain in someone who has schizophrenia, or any tissue from the bowel of someone who has irritable bowel disease, all of these will be normal. Okay, so although you have a disease but you don't have any structural abnormality, okay, this is not in the scope of pathology. Okay, so these diseases which have no structural abnormality, these are away from the study of pathology. What we study as part of pathology is diseases which have a structural abnormality. Okay, and this is what we call it the morphology of disease. Okay, so we should have something that you can see either by naked eye or under the microscope that can denote that there is actually a disease. Okay, so this is the main idea. We study diseases which have structural abnormalities. Okay, we don't study diseases that have no structural abnormalities. Okay, so in order to study these diseases based on these morphologic criteria, we need to know many other things which are related to that. So the disease itself, we should know the etiology of the disease, which is the cause of the disease. We should know the mechanism of the disease, how the disease happens, or what we call it pathogenesis. The third one, which is the most important, is the morphology of the disease, how the disease looks like either by naked eye or under the microscopy. Okay, and because we are clinically oriented clinicians, we need to know the link between the morphology of the disease and the clinical picture. Okay, so for example, someone who has pain, there may be underlying inflammation, and a sign of inflammation is pain. Okay, so we should see inflammation under the microscope, and this will correlate clinically with pain. Okay, if we see a structural abnormality under the microscope, also we can correlate this with the presence of mass. Okay, you can't be clinically seeing a mass and microscopically and macroscopically no mass. So we should correlate what we see in the clinical field with what we can see in morphology, or either by microscopy or naked eye. The disease also entails the study of the complications of the disease. okay, complications or sequelae of the disease, okay. Also, pathology is interested in the prognosis and fate of the disease. What's going to happen, okay? Prognosis, this is also very important. What's going to happen after this patient treated or untreated? So either treated or untreated, and if the treatment is successful or the treatment failed. So study of disease, this is a very important part, or this is actually the main meaning of pathology, okay? But how pathology in our life is interpreted, okay? How the pathology is translated in the hospital life, okay? This is what we are going to talk about now. Can you hear me and see what's written? Let me just check. Can you all see and listen? Okay, I hope that what I'm writing is actually can be seen quite well. So just give me a feedback, would be nice. Okay. So, clean this. So what is pathology in the clinical life? So like say, if you go to the UK, pathology means, as the meaning of this word study, it's actually under pathology in the UK is histopathology, but also there is microbiology, biochemistry, all of these, because these all can study the disease, okay? In America, usually they call histopathology, they call it anatomic pathology, okay? And in the UK, usually they refer to histology. So if they say histology, this means that they mean histopathology. So histology means histopathology, okay? So histology, anatomic pathology. Clinical pathology is like, say, in some Arab countries, including Egypt, clinical pathology equal like hematology and biochemistry and other stuff. But clinical pathology in other like countries means histopathology. So clinical pathology means histopathology in other countries, okay? Okay, so what's pathologist? Okay, this is pathology in general. And pathology, as we said, is the study of disease, okay? A pathologist is actually, pathologist is not an academic as it's actually in most of the Middle East, okay? Pathologist usually refers to a clinician, okay? It's actually a clinician who has the ability to recognize disease, okay? Morphologically under the microscope and macroscopically as well, okay? So a pathologist should have a very strong clinical background in order to correlate what he can see under the microscopy or by naked eye to what's the clinical background, okay? An example of that, like say, if you are a pathologist and you see abnormal cells within the urine, okay? Abnormal, atypical cells, okay? If the clinical background is red patches, this will be CIS. If the clinical picture is papillary neoplasm, this will be urothelial carcinoma. So this means that you understand, if you see abnormal cells in the urine, but you know from the clinical background that this is red patch, you should not say this is urothelial papillary carcinoma. But if they say that by the cystoscopy there was an abnormal growth or mass, and you see these abnormal cells, so you'll see urothelial carcinoma. So this is an example, and sometimes this question is asked in the interview. How can you correlate with the clinical background? Say, if you didn't have any criteria in the clinical request, but you got abnormal cells, and you went to the MDT, okay? And the MDT, they give you this information that this is red patch, and it wasn't actually papillary neoplasm. So your diagnosis will change to be CIS instead of saying this is papillary urothelial carcinoma, okay? So this is an example of the clinical background. We have many examples of that, okay? A pathologist, if you go like, say, if you are like with a taxi driver and he asks you what's your job, you say a pathologist, usually he will become scared of you, okay? Why he will be scared of you? Because pathologist is linked in the UK with post-mortem, okay? So if we say I'm a pathologist, they won't actually think of cancer diagnosis or that you are the one who is doing the biopsy examination. So no, they will think immediately of someone who is dissecting bodies, okay? This is why they get scared of you, okay? Okay, so if we divide pathology, generally we have 3 compartments of pathology, okay? 3 compartments. This is now the practical classification of pathology. The first one is the histopathology. So histopathology. The second one is cytopathology. And the third one is autopsy or post-mortem exam. Okay, these are the practical 3 parts of pathology. Okay, so what is histopathology? Histopathology is a study of tissues. Okay, so a study of tissues, and from its name, we are studying the diseased tissues. Okay, diseased tissues. Histopathology. Okay, cytopathology is examining the diseased cells. Okay. The autopsy, I don't like this name because actually if you compare autopsy with biopsy, they are different, okay? So autopsy, the best name is post-mortem examination, okay? So post-examination of dead bodies, okay? To find out the cause of disease, okay? And you should write the death certificate. Now the autopsy is declining, okay? And this is due to many things. Some related to some scandals, of like scandals of unauthorized retention of tissues. Okay, they found one of the hospitals that actually retained some tissues of children without getting consents from the patient parents. Okay, they didn't actually take any consent, and they retained some of these tissues. Okay. And especially those tissues which have symbolic like meaning, especially the brain and heart. Okay, when you retain something like that, this will be more scandalous than retaining other tissues. Okay, so this is what has happened in one of the hospitals in the UK. Okay, so after that there was what's called Human Tissue Act. The Human Tissue Act. This was in 2004. This act or like rules, like series of rules, restricted the use of tissues of dead. Okay, and one of them is actually you do not have any like right to do any research. So research on tissues, on dead tissues, is completely forbidden. Okay, it's completely forbidden. Okay. And in other uses, you should have like consents and many other things. Okay, so this actually restricted the use of tissues, especially the dead tissues, and also the change of the population view of autopsy. Okay, now it's hated; it's not actually welcomed as before. Okay, so autopsy now is declining for many reasons, although it's actually a good teaching tool for pathologists. Okay. Now we'll talk about histopathology and cytopathology. So cytopathology is to examine the abnormal cells. Okay, so these abnormal cells can be found in effusions. So effusion means the presence of disaggregated cells within a cavity. Okay, and these cavities, example for them is the pleura. So we have pleural effusion, or acidic fluid. Yeah. Or some fluid, say below the meninges. So any like collection of cells within a cavity. This is called effusion cytology. Okay. The other way to gain these cells is by what's called FNAC. Okay. So fine needle aspiration cytology. Okay. So you have a mass, and you need to get some cells. So you go with a needle and you may inject fluid, or sometimes you just make the suction of the disaggregated cells from that tumor or mass, and then you examine it. Okay. The other way is to get washes. Okay, so wash means like, say you are in the operation and you need to have more cells, so you like apply some fluid into the peritoneal cavity and then you wash the peritoneal cavity, take this wash and spin it and you get the cells. Okay, this is called wash. You can get also urine, okay, urine, and you can examine the urine, but on the other hand you can also make wash, bladder wash. You can inject saline and then you get cells. This makes you get more cells. You disaggregate more of the cells and then you get more cells. So by the wash you get more cells. You can do also bronchial wash, okay, but also injecting some fluid into the bronchial tree and then collecting this fluid, okay, so you get bronchial wash. You can get brushing as well. So brushing by a special tiny brush, you just can disaggregate more cells and take the brush, okay. So all of these you can get the cytologic material and then examine this material under the microscope. Histopathology is to get tissues, okay? So in order to get tissues, you have to have more solid areas, okay? You have to have, and in this actually, this is the most accurate diagnostic part of, this is more accurate than the cytology, by far, okay? So if you have something on cytology that's not, you are not actually quite sure of the diagnosis, you may ask for tissue biopsy, okay? So how can we get the tissue biopsy? Okay, sorry, I'll just take some time. Okay, so you can get the tissue biopsy based on the type of tissue and the site of the lesion as well. So like say if you are in the skin, okay, and you need to have a biopsy of a lesion in the skin, okay? So just imagine this is the lesion in the skin and you want to get part of this lesion to be examined under the microscope, okay? So you may go and take a punch biopsy. Punch biopsy, you will have like rounded cylindrical core of tissue like this, okay? So you go and take cylindrical small, and it has actually a regular diameter, say 6 millimeter diameter, and you can go for a certain depth. So you can get, this is what's called punch biopsy. Punch biopsy, you go by a certain tool and you go and take apart from the tumor. This is called the punch biopsy, and this is quite easy, and it's just done in the outpatient clinic and there is no problem with that, okay? The other way is to take what's called incisional biopsy. So incisional biopsy, you take a small part of the lesion or the tumor, and preferably to take it with a part of the normal as well, okay? And this is called incisional biopsy. So you take part and you leave the rest, okay? If this is proved to be malignant, you go and take the whole tissue with a safety margin, okay? The third way is to take it as excisional biopsy. So excisional biopsy means that you take it completely, you take the whole lesion, okay? And you send it to the lab for examination, okay? If this is proved to be malignant, okay, either you have a good safety margin in the report, or you need to go back and take more, and this is called re-excision. So re-excision means that you go and take more part of the normal, either due to the margin is involved, or due to the margin is inefficient, or like say for example 1 millimeter margin in a melanoma is insufficient, although it is actually negative, but you need to have 5 millimeter free margin. So you go more and take more of the tissue. This is called re-excision. So we have three ways of biopsying a skin lesion: punch biopsy, incisional biopsy, excisional biopsy, and then you take excision for margins, or re-excision if the margins are insufficient. If you have a tumor in the GI, the usual technique is to take it endoscopically, like you take endoscopic biopsies, and these are actually easy to be taken. So just by the endoscope, the endoscopists will go inside the GI and take a small biopsy. Usually these are taken with the endoscope itself. So the endoscope itself will have an end which looks like sometimes they call it crocodile. It looks like that. And it has like a joint here, so this will go and take a snip, a small part of the lesion or the tumor. And sometimes they can take multiple fragments, and this is why you can receive on the slide multiple fragments of tissue. This is the way they take it by the endoscopy. Okay. There is another way, which is an operation as well. It's called EMR. So EMR is called is endomucosal resection. Okay, so say for example you have a lesion, and that lesion is not highly invasive. Okay, but there is restriction of doing excision. Okay, so instead you do a special operation called EMR. EMR or endomucosal resection. You take the whole lesion with part of the mucosa without touching the muscle. Say for example someone who has high-grade dysplasia without invasion or with early invasion. In this case you can do a localized operation by taking only the lesion with surrounding mucosa and submucosa without touching the muscle of the esophagus. Okay, can you all see? Just a feedback. Okay. So, okay. This is another way. The other way is like say we have also endoscopic resection of tumors in the bladder. Say using the cystoscopy, you go inside the bladder and you take that tumor by cauterization. So you go cauterize all around. You can actually take part of the muscle without any problem. Yeah. And this is in bladder tumors. Okay. And other lesions, like say in the breast. Okay, if there is a lesion in the breast, you can actually do what's called FNEB. FNEB is fine needle aspiration biopsy. FNAB. Or I prefer to call it true cut biopsy. True cut biopsy. You go and you can do multiple passes. You can go and take cores of the tissue. Take cores, multiple. You can take multiple cores and put them on the slide. Okay, this is called true cut biopsy or FNAB. This can be done also in the prostate. Okay, this can be done in the prostate either transperineal through the perineum, or can be done from the inside the urethra. Okay. You can do chips as well of the prostate. Chips, okay? They go with a special tool and they cut through the prostate, take all of this tissue out, and this is usual to alleviate the retention, for example, in prostatic gland hyperplasia, but also it is a diagnostic tool, and sometimes it's done as a palliative procedure, okay? Just in someone who has prostatic carcinoma, he has retention and there is no way of removing the prostate. They can do some sort of chipping of the prostate without removing of the whole prostate. So these are like examples of different ways of taking the tissues, and all of these will be sent to the laboratory. We have different types of fixation of these tissues, and then we process the tissues, and we have two ways of processing the tissues, okay? Either we say for cytology, you can do quick fixation by alcohol. Sometimes no need for fixation, you do drying. By drying, just dry the cells and then stain them immediately. The other way is to fix, the other way for the tissue fixation, we have two ways. Either not to fix it at all, and this is in the frozen section. So in the frozen section, the idea is to make the tissue hardened. Okay, so you need to harden the tissue in order that you can make slides. Okay, so in order to do that, we freeze the. So, for example, like someone sending a tissue for margin. Okay, you need to know if the margin is negative or positive. Okay, and the most famous thing is what's called Mohs technique. Mohs technique, and this is they use it in skin cancer in order to know. not to remove too much tissue. So they send slices of tissues, and then you comment either this is positive margin or negative margin, and then they can stop at certain stage, okay? But margin comment in frozen section, you get the tissue that is fresh, and you put it in the frozen section, in the frozen section. In the frozen section machine, and you just you make the grade of the temperature up to -18, -20, or even more, in order to make the tissue hard. And then you can cut slices and stain them. The problem with this technique is that the poor quality of sections, the high amount of artifacts, this can happen with the frozen section. The other way, which is a little bit time consuming, is to use the what we call it permanent section, or the paraffin section. So we transform this soft tissue or the fresh tissue into a tissue that have the consistency of the paraffin. Okay, so in order to do that, you should actually expel the water from the tissue, and this is by using different grades of alcohol, and then xylene, so you can expel the water out of the tissue, and then you put instead soft paraffin and then hard paraffin, and then you can cut the tissue into very thin slices up to 4 to 5 micron thickness, and then you can stain the cells, stain the sections and see the tissue. Okay, so this is the general idea of pathology. Okay, now I'll move to the PowerPoint presentation. Okay, I'll see if you can see here. I may stop this video now because I need to move to the PowerPoint presentation. Okay, so I'll stop this now.